The letter arrived on a Tuesday. 3 pages, single-spaced, the operative sentence buried halfway down page 2. Coverage for the requested treatment is denied. The patient had just turned 53. She had paid premiums on this policy for 20 years. $400 a month, every month, for 240 consecutive months. She read it twice, then called the number on her card. The representative told her she could appeal. By the end of the year, she would file 14 appeals. Every one would be denied. The treatment was not experimental. It was a standard immunotherapy regimen for a stage 3 cancer detected in October. Her oncologist submitted the prior authorization that same week. The insurer's response, automated, came back in under 2 hours. The denial cited a clause saying the treatment was not medically necessary, given the alternatives. Her oncologist replied that the alternatives had been considered and rejected for documented reasons. The insurer denied again. Each denial took about 90 seconds. Each appeal took weeks. The mechanism behind those 90-second denials is not a doctor reviewing a chart. According to court filings in federal cases litigated against major insurers between 2022 and 2024, prior authorization denials in many large insurers are routed through algorithmic review systems. A medical director may sign off on hundreds of denials in a single shift, sometimes averaging well under 2 seconds per decision. The clinical record is not being individually reviewed. The denial signature is. The patient did not know any of this when she filed her first appeal, a 1-page letter from her oncologist's office citing the National Comprehensive Cancer Network guidelines for her cancer subtype. The denial cited the same guidelines, interpreted differently. The pattern is documented in regulatory complaints, internal interpretations of public guidelines that read, to outside observers, as reverse-engineered to justify denial. She filed a second appeal. Then a third. The denials arrived faster than she could write them. There is an industry term for this: denial management. The goal is not to refuse care indefinitely, it is to delay it. According to KFF Health Tracking, roughly 54% of denied claims, when appealed all the way through, are eventually overturned. The insurer knows this. The insurer also knows most patients do not appeal. Some statistics put the appeal rate under 1%. The math favors aggressive denial. The ones who fight often receive the care, but by then, weeks or months have passed, and some patients will not be alive to receive what they were owed. By her 6th denial, she had hired an attorney who specialized in ERISA, the federal law governing most employer health insurance. The first observation was procedural. The attorney requested the full administrative record, every document the insurer used to issue each denial. Under ERISA Section 503, the patient was entitled to it. The insurer took 6 weeks. When it arrived, several cited clauses did not appear in the version of her policy in effect at the time of treatment. This is where the story turns. The discrepancy between cited clauses and the actual policy is rare, but not unheard of in litigation. The attorney demanded a full external review under the Affordable Care Act, a binding adjudication by an independent third party. Roughly 40% of external reviews, according to federal data, overturned the denial. In her case, the reviewer ruled in her favor on the 7th appeal. Coverage was approved. Her treatment, by then 6 months delayed, began the following week. The treatment worked. The cancer responded. By the end of the following year, her team described her as in clinical remission, but the 6-month delay had measurable cost. Her bills, even with eventual coverage, included out-of-network charges from a hospital. Her plan would no longer fully reimburse for the delayed admission. Her share, after coverage, exceeded $40,000. She paid most of it from her retirement savings. The financial damage of a delayed approval equaled a decade of her premiums. The 7 appeals she filed before the attorney did not disappear. Several remained on her record as denied. When she renewed the following year, her premium increased. Some was age-banded. Some was attributed to claims experience. The insurer's communication did not parse the two. She inquired. She did not receive a meaningful response. What happened to her case in court? Very little. ERISA preempts most state-level remedies for delayed coverage decisions. Even when a patient prevails on appeal, recovery for damages from the delay itself, the financial costs, the medical consequences, is sharply limited under federal law. A patient who wins an external review wins the coverage. They do not, in most circumstances, win compensation for the harm caused by the months of denials. This is a structural feature of ERISA-governed insurance that policyholders rarely discover until they make a claim. The pattern, in aggregate, has drawn attention. The Senate HELP committee held hearings in 2024 on prior authorization practices across major insurers, with testimony from physicians, patients, and former insurance medical directors. State attorneys general have opened investigations. The Centers for Medicare and Medicaid Services issued guidance tightening prior authorization timelines for federally regulated plans. None of these restructured the system. Collectively, they document that this patient's experience, methodical, automated, attritional denial, is a system feature currently studied, not yet meaningfully reformed. What does this teach about reading your own policy? 3 things. First, the operative document is not the marketing brochure. It is the certificate of coverage and the summary plan description, which the plan administrator must provide on request under ERISA. Read both. Note the appeal process, the external review provision, and the deadlines. Most appeals must be filed within 180 days of the denial. Missing that window forfeits the right to appeal. Second, request the administrative record early. Under ERISA, Section 503, you have a legal right to every document the insurer used in deciding your claim. Request it in writing. The 30-day clock begins when they receive it. The record contains inconsistencies far more often than insurers expect a patient to discover, and an attorney can identify them. Many ERISA attorneys offer free consultations. The cost of the consultation is zero. The cost of skipping it can be very high. Third, the external review provision is the patient's most powerful tool. Once internal appeals are exhausted, an external review by an independent third party must be made available. The reviewer is paid by the insurer but is structurally independent. Roughly 40% of external reviews overturn denials, a higher reversal rate than internal appeals. Many patients quit at the second or third internal denial. The external review, often, is where the case is finally won. She is, today, alive. Her cancer is in remission. The $40,000 she paid out of pocket, she will not recover. The hours her family spent drafting appeals, scanning clauses, photocopying records, those will not be recovered either. But she did, eventually, get the treatment. Most patients who fight, win. Most patients do not fight. That asymmetry is the architecture of the system. Reading your policy will not change the architecture. But knowing where it leans tells you, when the moment comes, how hard you will need to push back. The fine print is not, in the end, fine. It is exactly the size that matters. If her fight stayed with you, the episode on how insurers reverse most denials that people actually appeal, while almost nobody appeals, shows exactly why pushing back so often wins. It is the door she walked through, drawn out in full. It is on this channel.